Let's get started. I'm going to introduce our Line IT or Vision IT program in our department, and then just jump to the Halcyon experience with the Line IT system. Okay, this is UC San Diego. The main center is in La Jolla, and then three regional centers there. So we do have North County, and then Inland, and then the South Bay. So as you see, those little camera system. La Jolla has the three aligner system and one gate CT system, and then each the North County has a one aligner T, one gate CT, and then the Inland one has a aligner T, and then we are looking for next one in South Bay. So this is our environment. We try to kind of unify the whole system over the across the or the regional centers and the main centers. Currently, you see the clinical implementation for the five different kind of category or the purpose. The first one is radio surgery. We've been implementing this service monitoring system from 2009, so it's about 9 years so far. So we have a lot of experience with the radio surgery program. And then secondly is a DIBH program for the lab breast, also the mediastinum IMRT. We use the DIBH program. And then one of our regional centers initiated this tattoo list project. So it turns out really successful results from the feedback from the patient. Also, the therapist really happy with those results. So we kind of try to implement across all the UCSD centers right now. And then there is any extremity or the sarcoma patient, we prefer to use this surface monitoring technique. And then gate CT is another technique. We kind of parallelly use the RPM and also the gate CT technique. And then whenever we have some high risk case, I'm not sure the high risk is the right word, but the more like the SBRT, spine SBRT, and we want to really pay attention if there is any gross motion or errors. While we register those cone beam CT images, and then we may not necessarily caught or the problem. So this is the great way to active monitoring. So far, over 9 years, we kind of published a couple of publication papers. The first one is clinical outcomes. The recent publication, the neurosurgery 2015, and then there is a rapid the VMAT multi-MAT cases, and the three series of translational cancer research is about the TRISAM and the multi-MAT, and then there is another one is the clinical outcome data update. And then there is another one is the neuro-oncology about the benign Basker cases. So much we publish more our outcome data based on the LINRT system. As the risk assessment, we started with the TG100 based FMEA study. So we listed all the possible failure mode based on the service monitoring. And then the next year, we implemented different risk assessment technique. So traditional FMEA versus the healthcare FMEA. So we kind of see the contrast of the risk assessment technique. And the third one is the system and control theory-based different risk assessment theory, and then we kind of compare with the FMEA study. So the over 3 publications, we can analyze or the possible risk, so we can place any corrective action into our clinical workflow. So this is third part is the technical aspect. We published so far 2 recent. We do have a lot of, all 2009 and 10, and Laura Cervino published a lot of preliminary study with the LINRT system, and then this is a recent study for the isocenter calibration. You might know, if you're the current user, you might know the isocenter calibration module for the MV-ISO versus the camera isocenter calibration is a great tool. You can cut any kind of minor detail problem and then fine-tune to your beam isocenter. And then there is another publication is the prospective, action limit designing per your patient plan. So think about your metastatic cases. So you have off-axis targets everywhere, and then you use the same tolerance to stop the beam and then reposition or correct some issue. So it depends on how the metastatic is off-axis from your isocenter. You can design those tolerance to stop to achieve your coverage. So this is the publication in the medical physics. So the very nice Halcyon system we installed recently, and then we are about to, actually we installed about the time of Astro, and then this is really wonderful machine, fast delivery, and then easy to drive, and then less problem, and then less machine fault. So I'm really happy with this machine. That basically ring entry, the bore diameter is about 1 meter, and then lower isocenter, so isocenter is lower than traditional C-type Linux, and then 185-degree from top to clockwise, counterclockwise, 4 RPM. This is amazing. Without the beam, 4 RPM. With the beam, 2 RPM. So usually true beam is 1 RPM. So you can imagine how it is fast delivery overall. So in terms of delivery time, is if you think the true beam is about 10 minutes time slot, and then the Halcyon will deliver all the beam same kind of beam within 7 minutes or 5 to 7 minutes. So from the get into the bunker and then get out, it's 7 minutes. And then all the motion is behind the cover, so there's no worry about the collision or any issues. And the couch is 3 degrees of freedom. That's a little bit limitation as a physicist aspect. It's a little bit limitation. But it has a lot of good features in terms of couch tracking, and the MPC is tracking all details about the couches, isocenter information. And then there's a live view camera. It's mounted at the end of the couch, so it's to keep monitoring the patient through those camera system. And then virtual ISO. So there is some laser set, and the virtual ISO exists, the same as your CT scanner. And then the rear ISO is invisible. So basically, there is no field lights, no crosshair, nothing there. So basically, you can see the isocenter. There's no way you can check the ODI. So that's very fantastic. At the same time, it's a little bit blind spot as a physicist. The beam is a 6 FFF, 800 monitor unit per minute. And then MLC, the dual MLC play together. It's really nice play, fast delivery. So when you install a new machine, you kind of think about how I can improve my workflow. I mean, once I design the workflow and then I propose a therapist, and then we kind of work together until the settle down, like a happy point. So this is my approach. We call it DMAG. The create a process map, and then measuring the time cost, and then evaluate the difference of positioning accuracy, and evaluate the difference of imaging dose. And then when I complete my DMAG exercise, and then I can keep monitoring how it is working. That's the final goal of this DMAG project. So as a workflow, this is the usual workflow from the patient setup, imaging, and treatment. When you look at the imaging portion, this is what happened if MV cone beam or MVMV beam has embedded some rotational misalignment. For example, head rotation, roll, or pitch. And then the therapist go into room, take off the mask, correct, and even you can pulling out the patient from the ball, not like a true beam, you just touch and get out. It's pulling out the patient, adjust, and push back. So which is really, we need something better tool to correct those rotational error. That's how we come up with the alternative solution. So we set up the alternative system into the patient setup flow. So plug in this stage about 20-second work adding. Actually, we get rid of additional imaging portion. So this is current hour layout. It's from the top to the bottom. So Halcyon machine, there's the beam ISO, And then there's a setup ISO, actually called the virtual ISO. And the two camera systems are looking at the virtual ISO right now. So calibration self of the camera is to the virtual ISO like this. So we'll align the laser in the virtual ISO calibration. And then actually the virtual ISO is QA'd by the NPC, virtual ISO versus beam ISO. So we keep tracking by the online QA system how it is well matched, usually within the 0.2 millimeter range. So this is the picture of how our therapists set up the patient on the Halcyon with the aligner T system. So once the therapists pay attention more rotation rather than translational. So translation is easily corrected by the couch. So the rotation is the most crucial information for the therapist to set up. So once they are happy with the position, and then we kind of push through one button. That's it. One button and beam on. No, imaging auto register automatically, and then just ready to go. So it is very fast. So our initial comparison is the treatment side brain MRT. So maybe people want to know why brain, but that was our first case. So I think this is great start. And like a GBM kind of disease site, we start with initial observation, 35 fraction pre-aligner T installation, 35 fraction for the post-aligner T system. This, the patient set is the cone beam, MV cone beam setup field is used for the calculation. So measurement quantity is the treatment time, dosimetric effect for the imaging, dosimetric effect from the setup accuracy. Oh, there's supposed to some photo there to show what is our brain MRT looks like. So we use the S-frame, customized head cushion, and then head short mask is what we are using. So this is the graph of the total treatment time from the start imaging and then finish the treatment. This is the measurement. So with the aligner T, the red column is with the imaging system, and without SGRT, sometimes we need a recon beam to adjust the position. So that's over like 6-7 minutes. Sometimes go into the room, the door is very slow, so walk into the room, taking out the patient, and then take off the mask, adjust, put it back, and push it into the machine. So you can imagine how it is kind of a big hurdle for us to use the best machine in the best way. So this is the comparison of the patient, same patient without the aligner T, and then down this one, same patient, IMRT case with the surface monitoring. So you can see the difference of the most improvement will be a roll and pitch direction. So here we analyze the register rotation error with or without the SGRT. So pitch is the great role to improve the accuracy of the setup. So we can compare these old numbers. And there is the electronic poster presentation Wednesday. So if you're interested, you can ask it. Ever is a great job for this the study. So this is the initial study was for the 35 fraction, but we extended to the 100 fraction data analysis and then try to publish it. So this is the impact from the imaging dose. So when we talk about the imaging, we easily talk about the cone beam, KB cone beam, but this machine uses the MB cone beam. So when we planning in the Eclipse, we consider the one cone beam into account our planning dose. But when we need to adjust the position, then we need to, it's a dilemma. If you want to make a perfect position, then you need to replan for the next fraction, or you kind of hugging those as the uncertainty. So this is the calculation from the, if you add one more cone beam for the adjust position, how much you need to deal with those effects. So it's not necessarily huge, but still this is MD, so it's not necessarily negligible dose. So if this is an MRT brain, since there is the optic nerve and the chiasm is nearby, and then when we approve the plan, we kind of see the max point dose, which possibly push those point max to the over what we comfortable area, which is 55 gray or 54 gray, depends on your department policy. That will be the kind of a hard line to talk about. There is a tons of study about the rotational error, how introduce the dosimetric impact in terms of 1 degree rotation, 3 degree rotation. So I think this is very similar results we will get with the 10 fraction analysis. So the coverage will be not as significant as the SRS for sure, because this is IMRT, but still it will impact the optic chiasm and nerve, also the coverage, the CTV too. So this is so far what we did for the brain IMRT case. We have some current ongoing for the breast setup with the Halcyon LNRT, and then there is the coming ongoing project is the HyperArc. So we're starting the HyperArc with the LNRT system, so we need to re-optimize our workflow based on the HyperArc LNRT system, which is a little bit different mask system. Also, there is an intra-arc imaging, which might be affects the monitoring quality. So those should be considered when we commission the system. Thank you.